So we'll start off talking about bicommissural aortic valve. These are data that Julian Hoffman and colleagues put together a few years ago. It was a very lovely paper looking at the prevalence of congenital heart defects in the United States in the year 2000, and a cumulative study from the 1920s actually, or 30s, when data really were available, to see how many patients there are with congenital heart defects. And one of the outcomes of this study is, if you sum up, these are simple, moderate, and complex lesions, but excluding bicuspid aortic valve or bicommissural aortic valve. So the total simple lesions here is about 1 million. There were about 300,000 moderate, and about 450,000 complex. So that comes out to a little under 2 million, 1,700,000 or something like that total. But if you look here at bicommissural aortic valve, it's 3.6 million. So this is substantially more prevalent than all other congenital heart defects put together. So bicommissural aortic valve is a very important disorder numerically in the world, and accounts for probably more morbidity and mortality than all congenital heart defects put together. So just to point out the importance of this. The anatomy is interesting as well. These are data that Sue Fernandez did at Children's some years ago. We actually did the first study of this, and then she came in and repeated it a few years later. But if we look at all patients, we did a study here of about almost 1,200 patients with bicuspid aortic valve from the echo database to see what the morphology of the valve was. And about 70% of all bicuspid aortic valves have an absence or fusion of the intercoronary commissure. So that's by far the most common, twice as common as any other kind, almost three times actually. The next most common was the right non-commissure, which accounted for almost 30%. And then the left non-commissure is almost always present. Only in 1 or 2% of abnormal aortic valves is the left non-commissure absent. So this is the distribution of all patients. But if you look, for example, at aortic coarctation, what's interesting is that almost 90% of patients with aortic coarctation have absence of the right, left, or intercoronary commissure. So it's very specific in coarctation. Whereas patients who have more progression of aortic stenosis, of intrinsic valve disease, have more or more likely to have right non-commissure involvement. So there really does seem to be some implications as far as outcome is concerned on the anatomy of the valve. I'll just show you the anatomy of one valve here, and this is the most common type. Here you can see we're looking into the aortic root here. This is the valve. Here's the right coronary artery opened over here so you can see it. Here's the left with the circumflex and anterior descending coronaries. So we've reflected the aorta back here. And here's the aortic valve leaflets. You can see that they're very thick, not quite normal, very fleshy appearance to the valve leaflets. And you can see that there's one commissure that's over here, right there where the probe is. That's between the left and the non-coronary leaflets. So the left non is present. Here's the commissure between the right and the non. So the right non is present in this case. And there you can see that commissure. And then the one that's missing is the most common one to be missing, and that's up here between the coronary arteries. Usually there would be a commissure here between the coronary arteries, but in this case it's missing. And in fact, you can see that there's a raphe right here. This is an unformed commissure, if you will. It's where a commissure would have been, but in fact there's just a thick connection of the leaflet to the wall of the aorta. So a commissure is a separation between the leaflets that goes all the way to the wall, and here you can see this would have been one, but it failed to form, or fused after it formed. I don't know what exactly the mechanism is. So that's a fairly typical bicommissural aortic valve. Now, the outcomes, as far as we know, and there have been a couple of studies looking at long-term outcomes of this, about a quarter, roughly, of bicuspid aortic valves can function for a lifetime and don't function at least well enough that valve surgery or substitution isn't actually necessary. But that means that about 3/4 of bicuspid aortic valves produce enough valve disease, either aortic stenosis or insufficiency or both, so that the valve requires some kind of intervention, and that's often a valve replacement. Usually this does not occur before the 6th or 7th decade of life. It's uncommon for an isolated bicuspid aortic valve to cause a lot of trouble before that. We do see a few in children who do present with problems, but the majority present later in life, after the 4th or 5th decade, with enough valve disease to require, after the 5th or 6th decade, rather, with enough valve disease to require replacement or treatment of the valve. The other problem that has more recently become apparent with bicuspid aortic valve is dilation of the ascending aorta. This seems to be a genetically determined phenomenon. This does not seem to be a hemodynamic response of the aorta to some unusual flow pattern through a bicuspid aortic valve. It seems to be related to abnormal fibrillin in the ascending aorta, to abnormal release of matrix metalloproteinases. Normally they're sequestered in the ground substance or the matrix of the aorta, and there seems to be abnormal release of proteinases that then can reduce the tensile strength of the aorta and result in aortic root dilation. And there is a modest lifetime risk of infective endocarditis in patients with bicuspid aortic valve, although it seems to be relatively low. So then the next thing that I want to talk to you about is the most frequent type of valve that we see in neonates and young children is the unicommissural aortic valve. And here's an example of a neonate with this. Here we see the right atrium. Here's the foramen ovale, which is open. There's often shunting from left to right in patients with aortic stenosis. Across the foramen ovale like this, there's a little hole down here also, so it has both types. Here's into the right ventricle, which looks reasonably normal. Here's a little bit hypertrophied, but this is a newborn, so one would expect some hypertrophy. The outflow, the tricuspid valve, the right ventricle, all look reasonably normal in this patient. And as we turn over to look in the left ventricle, we'll see there are some papillary muscles here are a bit hypertrophied. You can see the septal surface here. Here's the mitral valve, which can be abnormal, but in this case looks reasonably normal. The papillary muscles are a little bit closely spaced. Here's the left ventricular outflow tract. We can see the aortic valve from below, but not very well. But when we look from above, here you can see the aortic valve, and the only commissure that's present is this one back here. The other commissures are all Raffets. So there's a continuous leaflet all the way around, and only the one commissure present in this example. Here we see the foramen ovale in the left atrium, and you can see the opportunities here for left to right shunting, which often occur. The appendage is up here. Here's an adult, or a teenager actually, who had the same kind of valve, and I think we can see the morphology just a little bit better in this example. Here we're looking again down into the aorta from above. We're looking into the sinuses. Here you see the commissure that's present in this valve, which is pointing back here. This is the left non-commissure, the one that's virtually always present. The left would be over here, and the right would be over here, and the non would be back here. So here's the This is all non-commissure back, non-coronary. This is the left and this is the right. Here's intercoronary and here's right non over here. So you can see that there are two raphes that are present here that would have been commissures but never formed. And the only commissure that's present in this valve is the one back here coming to the left non area. You can see that the endocardium here is a little bit bright, probably some endocardial fibrosis in this patient. Here's the smooth septal surface. Here's the mitral valve, which looks pretty normal here. Papillary muscles and all look reasonably normal, although there's some thinning of the papillary muscles and maybe a little bit of fibrosis of the apex of some of these papillary muscles. And there you can see up to the aortic valve leaflets. There's mitral to aortic continuity. So the treatment for most neonates and young children today, I think, is balloon dilation. I think this is what most people prefer, although there are still some groups that prefer surgical valvotomy to this because they believe that it's a more precise and controllable procedure. I think this can be debated one way or another, and I don't know of any really very good data. There are a couple of papers comparing them, one from years ago from Benny Zevi, actually, when he was at Children's, did a paper like that. I don't know of any very good data comparing surgical and balloon dilation in a reproducible way. Other options for treatment of this are the Ross operation in patients who either fail valvotomy because one simply can't reduce the gradient either with a balloon or at surgery, or because they develop more than moderate aortic insufficiency and become ill from the aortic insufficiency often created by the treatment. So that a neonatal Ross operation may be necessary in a subgroup of these patients. Some of these patients also have very severe annular hypoplasia, in which case it's simply not possible to create an adequate left ventricular outflow tract, in which case a Kono type of operation in which one splits either into the interventricular septum, or there are other operations where one can split into the anterior mitral leaflet to enlarge the left ventricular outflow tract so that one can put in a larger prosthesis, either moving the pulmonary valve into that space created or by putting in a homograft or something of that sort. So there are a number of ways to manage this, and basically depends in part on the response to more simple kinds of treatment like dilation or surgical valvotomy, and then these being reserved for situations in which that's not very effective. One outcome study looking at a fairly large number of patients with infants under 6 weeks of age, or even less, 60 days of age it was, with severe aortic stenosis who all underwent a balloon valvuloplasty. You can see that the mortality rate here is not insignificant. 14% of these patients died. In addition, 6 were converted to a single ventricle approach simply because the left heart proved to be inadequate to support the systemic circulation. 15% also developed moderate or more aortic insufficiency when essentially none was present before. So you can see that there is a substantial risk for development of significant aortic insufficiency after balloon dilation. The mean gradient reduction was about 54%. And I think this is one of the important points, one of the important principles of treatment of severe aortic stenosis in neonates and infants, and that is that one doesn't want to abolish the gradient. One wants to reduce the gradient to the point that the left ventricle can manage it and produce an adequate cardiac output, knowing that it's possible to retreat in the future. And attempts to really reduce the gradient much more than that generally result in an unacceptable amount of aortic insufficiency. The 50% gradient reduction occurred in almost 70% of the patients. 50% gradient reduction at this level is really quite substantial and usually sufficient. The other data that they were able to produce was to look at what happens to aortic annulus growth, and you can see that there was substantial growth of the aortic annulus, actually within the first year, not so much after that. And also to look at the left ventricular diastolic dimension. You can see that there was some increase also in the left heart size up above -1 z-score in most of the patients by a couple of years or 3 years after the procedure. If one looks at reinterventions, what actually happened to these patients then, we can see that this is freedom from aortic valve replacement, and you can see by 5 years, about 80% were still free of an aortic valve replacement. By 10 years, it was about 70%. If we look at just repeat valvotomy, by 5 years, only about 55% were free of a repeat valvotomy. So most of these babies will undergo a repeat procedure on their aortic valve in early childhood. By 10 years, about 40% were still. So most of this occurs in the first 5 or 6 years, but there's a substantial need for retreatment of neonatal aortic valve disease that's undergone balloon valvotomy. And here you can see the freedom from aortic valve intervention, or left ventricular outflow tract intervention, is really pretty low by 10 years. Only about 25% had not had something done to their left ventricular outflow tract by that point. Coarctation or mitral valve intervention were much less frequently needed, fortunately. So let's just look at one example of supravalvar AS, and then we'll move on to the next. Here's the opened ascending aorta. This is the aortic root down here with the valve, and here you see the sinotubular junction at this point, and you can see that the primary narrowing here is right at the sinotubular junction, and look how thick the sinotubular junction wall is here and how thick the ascending aorta wall is. These are the brachiocephalic arteries, and you see that they're slits. There's often stenosis of that, and look how thick this carotid artery is cut up in the neck. So this is a diffuse vascular disease where there's marked thickening of the intima media of the vessel that predominantly occurs around the sinotubular junction, but it occurs throughout the vascular system, causing diffuse narrowing. Here you see the left ventricle in this patient. There's again some endocardial fibrosis here, although not marked. There's ventricular hypertrophy, as you would expect with any kind of aortic stenosis, but otherwise in this patient the left ventricle looks okay. This is the pulmonary artery. This is a non-Williams patient. This patient had isolated supravalvar aortic stenosis, and here you can see the pulmonary arteries are nice, thin, normal-looking pulmonary arteries, and the right ventricle also looks normal in this patient. So we'll stop at that point and move on to...
Thanks, Steve.